Since 2017, a patient at a Novant Health clinic in North Carolina paid $75 per visit for a blood draw and an office consultation. Then the bills changed, roughly $400. Same clinic, same doctor, same blood draw. In 2012, the Medicare Payment Advisory Commission documented that Medicare paid $124.40 for a 15-minute office visit at a hospital-based practice, and $68.97 for the identical visit at a private practice. At the University of Miami Hospital, a 30-minute clinic visit carried a facility fee of $1,500 stacked on top of the physician's bill. 2 bills for 1 visit. That second bill is called a facility fee, and most patients assume it pays for hospital infrastructure, emergency backup, overnight staffing, operating rooms. The building the fee attaches to often contains none of those things. The facility fee does not follow the building. It follows the owner. Between 2007 and 2013, the number of physicians folded into hospital systems nearly doubled, according to a December 2015 report from the Government Accountability Office. By 2024, at least 47% of American physicians belonged to hospital systems, up from under 30% in 2012. Private practice shrank to 42% of physicians, roughly 80,000 fewer than a decade earlier. The Medicare Payment Advisory Commission, known as MedPAC, spotted the pattern early. In its March 2013 report to Congress, MedPAC warned that the higher outpatient department rates could push hospitals to buy physician practices and reclassify them. A health policy researcher at George Washington University, Ali Moghtadari, laid out the arithmetic plainly. When changing a location's designation turns a $100 payment into a $250 payment, the designation gets changed. What makes this harder to dismiss is an academic study cited in MedPAC's own June 2017 report, which found that at many acquired practices, the substantive changes stopped at the nameplates on the door and the source of the staff's tax forms. Same exam rooms, same nurses, same equipment. Patients assumed the second bill described a different kind of facility. What that second bill actually described was a different kind of paperwork. Every one of those reclassifications, every $75 visit that became a $400 visit, runs through a single federal rule published in the spring of 2000. That rule is where the 2-bill structure was born. On April 7, 2000, the Healthcare Financing Administration, the agency now called CMS, published a final rule in the Federal Register. The rule created the Hospital Outpatient Prospective Payment System, effective August 1, 2000. Congress had ordered it 3 years earlier through the Balanced Budget Act of 1997, signed on August 5 of that year, a law built to cut more than $116 billion from Medicare spending over 5 years. The rule split outpatient care at hospital-designated sites into 2 separate payments, a professional fee to the physician and a facility fee to the hospital. Here is where the door opened. Under the federal provider-based rules, a site qualified for hospital billing through organizational integration with a hospital, not physical location inside one. An office building miles from any hospital could bill as a hospital department the day its ownership changed. The warning existed in writing before the system switched on. In 1999, a full year before the rule took effect, the Office of Inspector General at the Department of Health and Human Services flagged the provider-based designation as producing increased costs with no documented benefits and recommended eliminating it. The Inspector General repeated that recommendation in 2016. The designation still stands. Congress finally acted in the Bipartisan Budget Act of 2015, but the law applied lower rates only to new off-campus sites and permanently grandfathered every site already billing. As of 2022, the reformed sites accounted for 2.3% of Medicare outpatient spending. The other 97.7% runs on the 2000 structure. Medicare outpatient payments climbed from $58 billion in 2015 to nearly $75 billion in 2024, while visits per beneficiary stayed flat. 16 states introduced more than 24 bills on facility fee billing in the 2026 legislative session alone. Connecticut bans the fees for most off-campus outpatient visits, and Indiana followed in July 2025. Most states carry no restrictions at all. At the federal level, CMS extended site-neutral rates to Drug Administration billing in 2026, with projected savings of $290 million against a system approaching $75 billion. The 2026 appropriations bill requires off-campus departments to bill under their own provider number starting in 2028, a disclosure change, not a payment change. Senator John Kennedy's Same Care, Lower Cost Act, introduced in May 2025, remains pending. Meanwhile, physician consolidation reached 47% and keeps climbing, and each acquired practice adds new patients to the two-bill system. The rule took effect on August 1st, 2000. It has now outlasted 2 Inspector General recommendations for elimination and every presidential budget proposal since 2015. It is still running.